Sir, Dr. Rajendra Chandak sir, Dr. Harshad Argekar sir and Dr. Deen Dayalan sir to please come up on the stage and moderate this session.
Good morning everyone. Moving on to the next live surgery. This is a case of a 55-year-old lady who is a homemaker, nil medically, had a history of slip and fall at home 10 days back. She came to the emergency room with the following pre-op x-ray. So this is a case of closed right distal tibia and fibula fracture without DNVC. Surgery planned today is closed reduction, internal fixation with nailing for tibia and open reduction and internal fixation with plating for fibula. Surgeon Dr. B. Shivshankar.
Start? Okay. Good morning everybody. This is a X-ray of 55-year-old lady with a 4 days old very distal fracture of the tibia and fibula, as you can see here. My plan will be to pass a Supra Patellar nail.
So I think we lost your audio.
Supra Patellar approach, and then as the distal fracture is very small, and I'll stabilize the fibula with the intramedullary wire. Then if required, I'll add polar bolts. So this is my plan. To get the alignment, I might use a calcaneum pin so that the assistant will be comfortable in giving a traction. So this is my plan. Thank you. Friends, the steps of the surgery were: the patient was positioned with the leg on two pillow so that it is slightly elevated and the opposite leg will not come in the way while the surgeon is operating, and the surgeon stands on the medial side of the leg, and the CM, AP and lateral can be obtained very easily. The knee joint is insufflated initially with about 50 or 60 ml of saline. Then a finger breadth above the superior polar patella, a vertical incision is taken for about an inch length, and the quadriceps mechanism is split in the center up to the superior pole of the patella. Then finger is inserted to see the ballatability of the patella and the tightness of the knee joint. And in this case, as the knee joint was very tight, I had to put a patella clamp and lift it up before inserting the protector sleeve. Through the protector sleeve, guide pin can be passed very easily. In this case, we also did pass a Steinman pin at upper 2/3 with posterior 1/3 in the proximal tibia. This will help in passing the guide wire very anteriorly, and also the nail will be in the proximal part of the proximal canal. It is very useful in upper third or upper fourth tibial fractures. May not be useful in a very distal fracture of the tibia, but it will be very useful in the upper fourth fractures, where I pass the Steinman pin about an inch above the fracture at the junction of anterior 2/3 with posterior 1/3. The nail will be restricted to occupy the anterior canal in the tibia. This is the position for C-arm for the AP of the whole leg. The X-ray tube is below the table and the image intensifier is above. This is the lateral picture for the whole leg. The X-ray machine can be moved along the table to see the whole length of the tibia. Here you can see patella clamp is being used to lift the patella as the knee joint was very stiff, and a cannulated reamer and trocar is being inserted. Here you can see the guide pin is being passed just medial to the lateral tibial eminence in AP picture, and just over the sweet point at the junction of anterior and superior surface of the tibia. Here you can see the Steinman pin passed in the proximal tibia at the junction of anterior 2/3 with posterior 1/3, which helps in keeping our reamer anterior in the proximal tibia. This is very, very useful in proximal tibial fractures.
And I have already reamed, the canal is very tight. I have reamed up to 8 millimeter only. And
So can you explain the supracondylar wire and the clamp which you put
no,
around?
I don't require reamer, plain guide wire you can put. Okay. See, what I did was I insufflated the joint with saline, and then the knee was very stiff. This is the first time I am seeing such a stiff knee. I tried to ballot the patella, but it was not coming, so I used the patella clamp to lift it, and I passed the guide wire. You can see that my assistant is lifting the tibia with the Steinman pin, and then I have taken the entry. The sleeve was not going totally, you can see, but since I was passing a guide pin only, I have passed it, and I have confirmed that it is going parallel to the anterior cortex in lateral view. Then the proximal tibial pin, whatever I inserted, that will help me to keep my reamer as well as the guide wire in the anterior part of the tibia. This is very, very important if the fracture is in the upper part. It may not be that important in the distal part, but another advantage of that Steinman pin is assistant can lift the tibia. There is minimal translation under anesthesia. The tibia goes upwards and the femur can be pushed down by the assistant. Since only the leg I have kept on the pillow. So that's what the advantage of this. You can see the entry from the top of the tibia where I have taken, and right now I have reamed with a cannulated reamer up to 8 millimeter, and since we want to ream it, we will ream now further. Dr. Atul Patil has joined me just now, and he is reaming the proximal end of the tibia. Yeah, with the 13 millimeter reamer which comes with a set.
So can you just hold on? We are a little confused. This is live or recorded again?
No, this is now, it is live is going on.
So Peter is saying it is recording, you are saying it is live, so it's a little bit confusing here.
No, okay, he says it is live now.
Yeah, now this is live. So what I can see is your sleeve is in place and a reamer is going inside.
Yeah, that's correct.
Yeah, so
Now
that's
the
live.
flexible reamer is going.
All right.
Yeah, and since we have already passed the guide wire, you can see the good alignment we have got, and we passed a tense in the fibula.
Yes.
So that we have stabilized. The reason why I had to do the surgery was the patient is very high risk patient. The ejection fracture is, as told by anesthetist, is just about 32. So again, like yesterday, I don't know, Atul wants me to do all complicated and difficult cases only. So luckily he has joined me now. So
can you show us the lateral of the proximal wire which you put in the proximal tibia?
take a video.
So just to get the audience where the wire is going in relation to the anterior and posterior cortex.
Yeah, that's correct. So you can see that now the Siam person has come now. Shoot. Yeah, you can see we have pushed the sleeve behind the patella by lifting that with the patella clamp. Now we will go distally, fracture set dakwa.
So the lifting of the patella is done specifically for this case because the knee was stiff.
Yeah, correct.
Not for every other case you would do.
Not for every other case, and you can see the lateral picture, it's very well aligned.
Yes.
Normally the book says that fix the fibula first, then go ahead and do the tibia.
Correct.
But I always pass the guide wire first in the tibia, then I will fix the fibula. The reason is when we have to manipulate, after fixing the fibula, if we manipulate the tibia for passing the guide wire, we might lose the fixation of the fibula also, especially if you have put some plates and if the fixation is precarious. So in such cases, it's always better to pass the guide wire first, then only fix the fibula. So that's what my routine is. Again, it is not written anywhere in the literature. That's my way of doing it, and I am very, very happy. Now you can see the lateral picture. The plain guide wire has gone. We have reamed up to 9.5, and Now, I'll just give some varus stress. Yeah. Now you can see that the guide wire has gone very distally.
So you just gave a varus stress to shift the position of the guide wire, or you put it through a sleeve, withdrew it and put it back in again?
Just withdrew little and gave little varus stress. The assistant is zoom out.
Shiva, good morning.
Good morning, Dhaval.
Shiva, what's the particular advantage of suprapatellar nailing for a distal fracture, just for my knowledge?
See, I am operating from the top. When the CM is going AP and lateral, I am not going out of the way. So, you can get a good picture of AP and lateral at the fracture site, and you are not moving the limb out of the way. If you are doing a figure 4 position or by the side of the table, then you are you have to go out when you have to take the CM pictures. Here, the AP and lateral is taken so beautifully that you need not have to get out of the way, and you can position your guide pin properly. Like we manipulated now very distal, AP and lateral, seeing the X-ray, we have manipulated the guide wire to the center.
So what's the risk of malalignment with the traditional nailing with this fracture versus, I mean, is there any risk?
I don't think there is any study, but after I started doing the suprapatellar nailing, I have not done even a single infrapatellar nailing. Yes, I have removed the suprapatellar nail from the infrapatellar approach, but definitely I have stopped the infrapatellar nailing because it is so easy to do in this position. Everybody is comfortable. The patient leg is not at all changed. The position once we are given, we don't change it. The draping will not become unstable because of the different position we keep giving for figure 4 position or under the table to take by the side of the table. All those things have made the life of me very simple. That is one of the reasons why I totally shifted over to suprapatellar approach.
Thank you.
So I can just summarize that.
Moreover, these suprapatellar nails are multi-lock nails. It can be, same nail can be used either for the proximal tibia or for the distal tibia or for the middle tibia. So my inventory also becomes in the operation. Since I am in a private practice, having inventory is also very, very important, and I don't get all the nails and the other thing immediately. If no sir, yeah, I am comfortable with that because we'll allow little collapse.
Sir, is there any bolster or pillow below the leg so as to raise it or flex the knee a little bit, or is completely extended?
No, it's about 15 to 20 degree flex. What I have done is, I have kept 3 pillows. The pillows, normally I keep 2 stiff pillows, but this pillow here was very soft, so that was more collapsing. That we can apply afterwards. So what we normally do is, we just keep the leg over 3 pillows, and the assistant lift, Vinod. So assistant lift the tibia here, and another assistant pushes the femur down,
Yes.
and I am operating from the opposite side. I am actually medial to the leg. So the other leg will not come in the way in the lateral picture. Even if you don't want that, you can flex the knee and keep, or you can keep it in the lithotomy position. That is another way you can do it.
The opposite leg, you can flex the opposite leg below the table.
Nail says. We have put a 932 nail, and we have confirmed by passing a identical guide wire by the side, and also we have kept the nail and taken a CM picture, and you can see once the nail is going inside, the alignment will be good. Now you can see that the Steinman pin above is helping me to keep the nail very anteriorly. This is very, very useful, especially if the fracture is in the upper fourth. So I keep this Steinman pin about 1 inch away from the fracture site, and that guides me the nails to that area where I want.
So in the anteroposterior thickness, where is the Steinman pin? Exactly in the middle, in the posterior 1/3 or in the anterior 1/3? The proximal.
Basically you imagine your nail. I am putting the 13 millimeter. The proximal end of the nail is about 13 millimeter.
Correct.
So you should have a gap of about 15 millimeter anteriorly. So 1.5 centimeter from the upper surface you put it. So now you can see that my nail has gone very distally, and Dr. Atul Patil wanted 1 more centimeter longer nail. I am more comfortable in inserting the nail more inside rather than using a exact size nail, because this nail I will if it allows little collapse, I'll be happy to collapse the fracture also. Once the traction is released, probably few millimeter collapse will also happen. So
does the nail have an end cap? If it is buried inside, you can put a half centimeter
yeah,
or centimeter
I
end cap.
think these are the Indian versions which don't have the end cap. You can see that my nail is just about 7 or 8 millimeter, and since there is an anterior flange for the nail, it will sit in flush with the anterior cortex. Yeah, I don't think it will irritate the patella in any way. Now what I am going to do is, I'll do the proximal 2 locking, mediolateral locking, then I'll go ahead and do the distal locking by freehand technique. So what I'm going to do is, now I can remove this Steinmann pin if it is required, but anyways, if it is not coming in the, yeah, it's coming in the way, we'll remove the Steinmann pin. Sister, drill.
So always proximal locking first, or in this case specifically?
What?
Always proximal locking first, or are you choosing it specifically for this case?
See, once I lock proximally, I can maintain the length and do that. And another thing is, once your major parts goes away, that is, you can do the distal locking easily also. But
so if you want to backhammer it, or you want to get some compression in
since
specific.
the fibula is not comminuted, I don't think we'll get any backhammering.
Not in this case.
Not
Sir.
in this case, yeah.
In any other transverse fracture?
No, I think we should hammer one more so that we can put one more. Yeah. Hammer, hammer. Give contour support. Shoot. Okay, I think it is not going.
Yeah, it's on that
yeah.
ledge which is there, the cortical ledge.
So since fibula is, yeah, we will remove this first. Yeah. So now I'll do the proximal only to mediolateral locking is more than sufficient in this case. AP kar do. Yeah. Ready kya? Yeah, thank you. Put the drill in the sleeve. Which are the two medial laterals? No, here. Okay. I think we'll do only dynamic locking. That should be more.
Yeah, I think one proximal lock should be.
Yeah, more than sufficient. Yeah. Knife.
So would you check the AP view also, because distally we can see the lateral, we can see good sinking.
I'll get back to you.
Yes.
Shiva, with this nail design, do you need that many holes distally, like 4 kind of? Does it make any advantage?
Whatever maximum is possible, I'm going to insert.
But Shiva, this nail has got one hole very high up and probably going into in the fracture side. So are you going to put the screw there, or you are going to keep it empty?
Yeah.
Shiva?
Yes, we are only going to put 2 screws distally. I'm not at all the person who will put a screw at the fracture site.
No,
yes.
But there will be then if you don't keep that, that will be an empty hole.
Guide wire kadla hai na? Proximally, you please come. Thoda oblique kar do. Shoot and save. So I have only passed the proximal dynamic locking, so it's 1 inch away. $30, $34. You please give me 34. Yeah, you can go ahead. Since since the angle blade plate is much more important surgery for all of you, I'll get back to you later on. If the other case is there, you can please carry on. Anand?
So I think this is a more common surgery than angle blade plate for most of people.
Thank you, because shoot, perfect, shoot, yes. I have done the proximal locking.
So this is
Now-
single dynamic lock proximal.
Yeah, normally I don't remove the proximal jig. I'll come back to the distal part now. Yeah, up kara. Table kali.
Okay.
Please.
Shivshankar sir?
Yeah.
Sir, we are about to start the case on the other side as well.
Yeah.
We'll keep watching you, sir.
Sure.
Thank you, sir.
Yeah.
The distal locking is done by freehand technique, and since I have not removed the proximal jig, we rotate the proximal jig so that there will not be any mis-rotation at the fracture site. So a sharp caver is taken. The distal lock in this nail has got two oblique locking options available. Either you can start anteromedially and go posterolaterally, or start anterolaterally and go posteromedially. So in the same hole, in two ways the distal most locking can be done. I am now doing from the anterolateral aspect to posteromedial aspect in this case, and you can see that round hole is seen and my caver is in the hole, in the center of the hole. Once I have drilled this with a thick caver, as the patient had a very osteoporotic bone, and also the bolts I am using can be used for drilling as well as tapping. So I am using directly the measuring guide to see the length of the bolt I have to use, and once the length of the bolt is selected, now I am passing the selected bolt in the distalmost hole, confirming under CM that my bolt is passing through the distalmost hole. Now I am doing the proximal of the distal locking. Initially I have taken a small incision, and through that incision I have passed a K-wire, and that K-wire is centered in the center of the moon. You can use the zoom options available in the CM, or the best way is lift the X-ray tube of the CM toward the leg or the table so that automatically zooming will happen. Now that my K-wire is the center of the hole, and I already hammered the K-wire through the nail, and once it is confirmed, now under CM, with the help of the drill, I am drilling the far cortex, and here the K-wire itself, thick K-wire is being used, 3 mm K-wire is being used to drill the far cortex and confirm that the K-wire has pierced the lateral opposite posterior cortex, and then the measuring guide is passed. The length of the bolt I have to use is selected. Normally I use 2 to 3 mm longer bolt so that it will come out on the opposite cortex, and as the anterior part of the tibia is very subcutaneous, we have to keep the heads of this bolt as flush to the bone as possible. Even you might use a countersink if you need some time. With a artery force hemostat, retract all the muscles and tendons at this area, then the bolt is passed and confirmed under CM that the bolt is in the hole properly locked. This is the CM picture showing the length of the
Screw, and you can see that it is very near to the fracture site. I have removed it. I'll be happy only to put the two screws. Shoot. I'm doing the shoot mediolateral distally now. Shoot.
Dr. Shiva,
Yeah.
the distal most screw which you have passed,
Yeah.
It is neither in the AP or a lateral plane.
Yeah, this
so
way.
any
Show me the nail. Give me a nail and 2 screws.
So any
One screw.
any tips how to get it right or get a oval hole, a round hole?
Yeah, give me a screw. See, the distal most hole, one could pass the screw in this position or in this position. The nail, whatever I have used, it can be passed in this position or this position with the same hole. So
it's an oblique lock distance.
Yeah, oblique lock. Yeah. So what you have to do is, don't remove the proximal jig. Control the rotation of the whole leg with the proximal jig. Can you see that? Yes. So I have not removed the jig yet. And seeing the oblique, the round hole is very, very important. I'll go back and show the CM pictures. CM pictures, go back and show the hole.
So you can rotate using the jig only if you have locked proximally, otherwise you will not be able to rotate the leg.
Shoot. Now I am going to do the distal most. Shoot.
Shiva sir.
Yeah.
Sure. Sir, is it not better to move the C arm and come obliquely rather than move the limb as such?
That is also possible, but see what happens is all the CM technicians will be not that intelligent, so it's better that we have some control with ourselves also. To shoot. Okay. Now you hold in this position. And move the CM thoda oblique kara. No, not opposite.
Shiva?
Yeah.
In this distal fracture, how do you ensure that you have rotated?
Ulta.
How do you ensure the rotational deformity? Because distally there is no landmark like a tibial crest. So how do you ensure that you have put the nail in a correct position?
It's only the fracture anatomy is one, and also I fixed the fibula. Now you can see, now I am doing the distal medial lateral locking second hole. Shoot. So it is very distal. Shoot. Shoot. You can see the round hole?
Yes.
Yeah. So getting that round hole, shoot. Okay. Give me knife. So normally I use only K-wire and I only enter into the proximal cortex, and then by hand I rotate and make the proximal hole little larger. Then I'll get across to the opposite cortex. Shoot. Anteriorly. Shoot. Proximally and anteriorly. No, not for you. Shoot. Shoot. So as soon as you get the tip in the CM, then you are inga zoom pannuva. See, this is the direction of the CM. Shoot. I have to drill this K-wire in that direction. Now what I am going to do is, I will make the proximal hole larger. I entered into the nail hole. Shoot and show and drill. Can you see?
Yes.
So now my assistant will make the leg more horizontal for me to be more comfortable. Now what I am going to do is, in the medial lateral position I am going to drill. Shoot. Yeah. Okay. And at this stage, if required, I can drill with the specific drill bit which comes with a set also, but I am okay with this because the patient is a lady, osteoporotic. Shoot. And
so in such lower fourth fractures with a fibula fracture at the same level, you always prefer a nail or a preference to a plate?
Somehow my preference has been for a nail, but I don't mind putting a plaster and making the patient walk with a plaster, because alignment 40. For me, alignment is more important, and once you get the alignment, you can just go ahead and ask the patient to walk with a plaster. So somehow my number of platings are far, far less. Hemostat. So I stopped doing it. So what I do is, if required at the end of the procedure, I'll add 1 or 2 polar bolts. In this case, there is more space medially, so I might put a medial polar bolt also. That will decrease the canal size and that will give some stability to the fracture. and prevent the toggling of the nail. Shoot.
So the polar bolt is flush to the nail so as to not allow it to move medially or laterally.
Yeah, exactly. Shoot. Since I am unable to put the proximal screw, which is very, very near to the fracture site, though it may not be seen in this view, it appears that it is quite higher up, but the proximal bolt I had put, and I realized that it is too much near to the fracture site. Now I'll put a polar bolt, which is normally 3.9 millimeter bolt. Shoot. Just medial to this at this, yeah, little distally. Shoot. You can make it straight. Yeah. Nice. So this polar bolt will help me. If the guide wire was not coming in the center also, I would have used a polar bolt at that stage. But since I have applied a calcaneal traction, it was easy for me to shoot.
So that time you would have put the polar bolt before putting the nail in.
Yeah, correct. So actually my plan initially was to put 2 K-wires to get the nail in the center and then shoot. This is my polar bolt drill. Rotate. See, this is the reason why I have not even removed the calcaneal pin, because shoot. Shoot and save. Yeah. I have got very good assistants, Dr. Vinay, Dr. Adnan, then very good OT staff, Vandana, Vaishnavi, all we. Shoot.
We are all together.
Yeah. Shoot. Thoda intel rotate karo. Shoot. I have not gone out. Shoot. Yeah. 38. Yeah. You can give 36. 36 sister. The sleeve is quite out. So this is a polar bolt I am passing. So this will go touching the nail, because my K-wire was just about 2 millimeter, 2.5 millimeter. I can feel the grating sensation which I am getting while passing this artery forceps. It's here. So always lift the soft tissue. My incision for the screw bolt is always very, very small. So I have to use this artery forceps to lift them, and then lift any tendons if they are coming in the way. Shoot. It little 1 or 2 millimeter longer, that's fine. Shoot. Removal of Steinman pin. Shoot. Okay. Are you happy?
Yes.
Yes.
So can we focus on the fracture side just to see
the
overall
remove this
picture?
So now what I am going to do is just little higher up. We are reducing the zoom, because instead of using the zoom of the CM, we lifted the X-ray tube higher up.
Perfect, perfect.
This is the AP. There are one oblique screw distal most, then there is one medial lateral screw, then there is one polar screw medial to the nail, and proximally one dynamic screw, and we have done the fibula wiring. I have to cut the excess length now. That's the only thing I have to do. And I am told that this set, whatever they have given, has the end cap. If required, I can put, but normally I don't use it. Sister, removal sati.
Shiva?
Yeah?
Have you transfixed the syndesmosis?
I don't think, because I'll show the view.
It is not a mortised view.
Yeah. Shoot. Even if it
intentional.
No. Even if it translates, it's fine, but it's not done. That's what I said, that my bolt was 2 millimeter longer. Now what I have to do is, finally I'll remove the jig, find out the AP and lateral picture of the proximal end, then I give a thorough wash and keep a drain for 48 hours. Come here, proximal end, shoot, shoot, okay, it's very well buried inside, shoot. I don't want that insertion, again we lose it in the knee joint. Lateral please, save that. Down, down, down. Anand, if you are listening, this video I require, I'll post it on my YouTube. Okay? Yeah. Friends, are you happy with this? Thoda KV kami karo.
Definitely, sir. Your copy will be here before you come here, sir.
Okay. Thank you. That's great, Anand. Okay. Thank you very much. I don't think I have to show anything else. I'll be putting a drain and washing, giving a thorough wash to the knee joint.
Thank you,
Thank
sir.
you very much.
Thank
Bye
you.
bye.
Well
I thank
demonstrated,
all the
please.
people. All the people, please come. Let your faces be shown. I must thank Dr. Sandeep Diwan, again my classmate during my MS time, who very expert. The ejection fraction of this patient was just 32 and he has given the anesthesia and the wrist. Thank you very much.
So the
Thank you.
big applause here in the hall for you.
Thank you. Thank
Well
you very much.
demonstrated.
Thank you. Bye bye.
Thank you, Shiva.
Thank you, Dhaval.
It's a treat to see you do a case other than a hip fracture.
Thank you.
So we
Quick recapitulation of all the things. The lady of 55 years with a comminuted fracture of the very distal part of the tibia. Plan was to nail both of them. With the CM picture for AP, the leg is positioned over a pillow. This is the CM picture for lateral view. The knee was tight, hence the patella was lifted with patellar clamp. Then a guide pin is passed medial to the lateral tibial spine in AP view and just at the junction of superior surface and the anterior surface in the sweet point, which is extra-articular. A Steinman pin is passed in the proximal tibia at the junction of anterior 2/3 with posterior 1/3. This will help to keep the guide wire and the reamer and subsequently the nail in the anterior part of the tibia. The reamer is inserted and guide wire is passed across the fracture site. Once the guide wire is entering the distal fragment, the fibula L wiring is done with a tense. A small curvature is given to accommodate the easy entry and return. Now the tense has been advanced further and the plain guide wire has been exchanged with a beaded guide wire for reaming purpose, the AP and lateral picture. The reaming is done. As you can see, the bead of the guide wire prevents the distalmost part reaming. So after reaming with the flexible detachable drill bits up to 10.5 millimeter, we have exchanged the beaded guide wire with a plain guide wire, and with the help of end cutting reamer, we have reamed up to the subchondral. Then the selected nail is inserted over the guide wire. This is the proximal end of the nail, which is well buried inside and will not cause any proud nail issues. Proximal locking is done in the dynamic part of the hole. The upper part of the nail you can see in the dynamic hole. The distal freehand locking is done. Distal most one here. The AP and lateral picture showing the final screw position of the distal most. The second one, mediolateral locking is done. The steps of locking. To enhance the stability of the fixation in the distal fragment and to decrease the canal size, a polar screw is added medial to the nail. As this screw was coming at the fracture site, very near to the fracture site, we did not think of inserting a screw here. Instead of that, we have inserted a polar screw here. As you, this is the final upper end of the tibia. Again, the proximal screw is in the dynamic part or the upper part of the hole, as you can see. This is the preoperative X-ray and this is the immediate postoperative X-ray. Well aligned fracture. Nicely, the nail is filling the canal nicely. Both tibia and fibula alignment are good. The interlocking is very nicely done. There is no proudness of the nail, and the chamfer cut in the anterior part of the nail is matching with the tibial anterior surface in the proximal tibia. Overall, a nicely executed surgery. Thank you very much.